live program, Let's Talk Health, Gynecology Queries. I'm Nidhi Kumar, and you're watching India Science. In this program, we take your questions live from Facebook and YouTube. And today we're joined by the very well known Dr. Anjana Singh, Director and Head of OBS and Gynae at the Fortis 62 Hospital, Noida. Namaskar, and thank you for joining India Science and Let's
My
Talk Health.
pleasure, Nidhi. My pleasure.
Ma'am, I'd like to begin with since we're talking about gynecology queries today, can you let us know about the scenario in India in view of the COVID-19 strains which had peaked up about 2 weeks back? Is there any specific protocol that you're following here at the Fortis hospitals? A lot of people are speculating. We have lots and lots of queries on gynecology today. But before that, a little bit about the protocol, ma'am.
Yeah. Nidhi, actually, after 2 years of COVID, since most of the people have been vaccinated, they've taken all the three doses. The number of patients who are coming to the hospital is lesser as it was last year and a year earlier. But still, we have not left the mask. Everyone who enters in the hospital has to enter with a mask, otherwise the entry is not permitted. And that distance maintaining is also still continuing. We don't make the patients sit too close in the OPD. And once they come for the consultation, and if they have been scheduled for some surgery or delivery, every patient has to undergo either a rat if it is an emergency, or if it is an elective case, then the patient has to undergo a COVID RT-PCR. It's only the if the COVID RT-PCR is negative or rat is negative that we are making the patient enter into our labor room or OT. If a patient is positive, then we generally refer the patient to a center where they have the COVID facilities. But then, at times what happens is that there are certain patients who come in labor, and they are in active labor, and we are not in a position to refer them even if they are COVID positive, or so in that case we are accepting such patients. We take them in a separate OT, and after the cesarean or whatever surgery is done, we try to totally fumigate the OT so that the other patients are not affected. But yes,
Absolutely.
the numbers are quite less these days, and that's a big solace.
That's a big solace and something to look forward to in future as well. I'd begin with some specific gynae questions, ma'am.
Yeah.
Um, I had been very recently from India Science to a hospital in Bengaluru, which was a government hospital, but it had the state of art facilities as far as labor room is concerned. It had
Yeah.
music, it had different kind of therapies. So, are
Right.
these things now coming up in India? People can look forward to something really soothing and peaceful while they're going through that kind of labor.
Definitely. Yeah, definitely. These days, the state of art labor rooms, I mean, they have LDRs. It's not a common labor room, where a number of patients are, just lying together. There's a concept of labor delivering suites, where a lady is in the comfort of her home. I mean, even the beds, they are not like any labor tables or anything. They're just like normal beds, and these beds get converted into labor table once the patient is in active labor. So a patient is absolutely, in a very home like environment. The interiors and the ambience is also as if she is resting in her bedroom. There's always a TV, and there's a music system which she can play at her will. Whatever kind of music she loves, she can play. Apart from that, there is the facility for the husband or whosoever wants to sit with her. Earlier, since all the females, they were lying commonly in a labor room, we would not allow the husbands because there was certain issues regarding privacy. But now, since the LDRs have come up, so every patient is she is being accompanied by her husband or whoever is comfortable, and she can she can actually feel emotionally, she feels very happy, and she's able to bear those pains because she's in the company of her near and dear ones apart from the doctors. And other than that, these days, we have the epidural facilities. Epidural is painless delivery. Earlier, it was told that all the mothers and mother-in-laws, they used to say, if you want to deliver, you'll have to feel that pain. Even we went through that process, so you also have to go through. But now these days, labor has become very comfortable. We give a anesthesia in the back, and because of which a lady, she doesn't feel the pain, but yes, the labor process continues and the baby keeps moving down. And it's only at the time of delivery that we tend to stop the epidural or the anesthesia, and she gets that sensation to push, and that entire period of her labor becomes a wonderful experience, because she doesn't feel that kind of pain which she was earlier, she was dreaded of. And these days, again, there is a concept of in water delivery. These days, there are big bathtubs and labor rooms, where a lady, she sits in the bathtub, and they're huge ones, and she delivers underwater. So the baby just comes out, and the baby is swimming and the baby is taken out. So that is also supposed to be a very, very comfortable way of delivering. Earlier it used to happen in the western countries, but now this concept is also, it started coming up in India, and there are many centers in Delhi NCR which are going in for water birth as well.
Absolutely. We have a question which is very interesting now. This is from Manoj Vargas ji. We have another one coming up. He says that there are many ladies who prefer cesarean C-section deliveries against the normal ones. Do you
Okay.
see any, health issues or any such kind of issues in this? And I would like to add to this question and ask you one more. Let's couple the two together. How do I get to know whether I'm going to have a C-section or a normal section unless I make a
Okay.
choice?
Okay, so I'll tell you, I'll answer the second part first. There are certain indications during pregnancy. I mean, some indications are absolute indications. Like, suppose, if your baby is breech, which means the head is up and the legs are down. So in such conditions, you cannot go in for a normal delivery, because the chances of head getting stuck is around 25%. Apart from that, if your placenta of the baby is low lying, suppose, I mean, the placenta is just touching the os and there are high chances of bleeding, in such cases, again, we suggest that you should not go in for a normal delivery. Apart from that, if she is if there are certain issues with the growth of the baby, if the baby is very, very weak, even in that case, I mean, the baby is not able to tolerate the labor pains, because of which she is not able to, she is not advised to deliver normally. And then there are certain conditions, like if she is hypertensive, if she has certain medical disorders. So these are absolute indications in which case a baby, a female, is advised to go in for a absolute C-section. There is, apart from the absolute indications, there are certain indications which happen in labor. Suppose a patient has been admitted for labor pains, but during that journey of labor, suppose the heartbeat of the baby goes down, or if the cord around the neck, it starts strangulating the baby, or if the baby passes some meconium, or if the water gets green, or if there is sudden bleeding during delivery. In all these cases, what happens is that we generally counsel the couple, and we tell them about the severity of the condition, and then they are advised to go in for a C-sec. So these conditions are called the emergency indications of C-sec. Now, see, I mean, how implications of C-section, as sir was asking. Basically, see, normal delivery is always natural. Once you deliver, if you deliver normally, the recovery of a lady after normal delivery is very fast, because she doesn't have stitches on her tummy, her abdomen is absolutely fine, and she doesn't find difficulty in getting up and moving and taking care of her baby, because she's the stitches that are placed during normal delivery are in the vagina, and they do hurt, but not to the extent that they may not allow her to get up. So after normal delivery, she can get up and take care of her baby. But after cesarean, it may take about 7 to 10 days for a lady to recover, and that time period for recovery is a little more in cesareans as compared to normal delivery. And then it is said that once you go in for a cesarean, the chances of delivery in the second pregnancy is also normal delivery is only 30%. So the norm these days is once a cesarean, always a cesarean. So that is why, we generally motivate females to, take good care of their body and go in for exercises and all, so that they'll end up in a normal delivery and cesareans can be avoided.
There's another question again by Dr. Manoj Varghese, and he's asking about the C-section delivery again. That complications are there, but what about the preference being made by pregnant, ladies to
Sorry,
proceed?
I can it. What was the?
The question is that the C-section delivery has complications is understood the same, but what about the preferences being made by the pregnant mother right in the beginning that she would like to go in for a cesarean
So
versus a normal
yeah,
delivery? How
this
often
is
do doctors listen to this? You mentioned the
actually,
breech condition, ma'am. So if
yeah.
the baby is breech or if the baby is a heavy baby, then it is understood. But sometimes women are opting for these C-section
Yes,
procedures.
yes. Yeah. Yeah. So cesarean on demand is very common these days, I mean, there are no absolute contraindications or anything. It's just because, a female, she doesn't want to go in for a normal delivery. So cesarean in demand is very common. But yes, if any female, if she is fit to deliver normally, and still, she wants to deliver by cesarean, we generally tend to counsel her. See, mostly we have seen that most of these times these ladies generally watch those videos on the internet and they get horrified with them. It's once you talk about the experience with your other colleagues and all, that doesn't horror you that much. But once you visually look a video, of a laboring patient and the patient howling and shouting, you tend to get demotivated and you don't want to deliver normally. So we generally ask them to abstain from such videos, and we try to counsel them. We try to tell them the benefits of normal delivery, and we try to encourage them to go in for antenatal exercises so that their body is fit for delivery. But still, if still the lady, she keeps on persisting that she doesn't want a normal delivery, then we have to comply to what she says, because ultimately the effort has to be made by the lady. We can't just pull out the baby. So I mean, she has to be involved in the
Willing.
process, only then she can deliver normally.
Absolutely.
Yeah.
I'll come to one more question related to this a little later. We have another question coming up, and this is by Radhika from New Delhi, and she writes that she has a lump in her right underarm. It was there before the birth of her daughter, but post delivery, its size has increased. Is there any reason to worry, or is this normal?
Actually, what happens is there is a portion of the breast which is called the breast axillary breast tail, and this axillary breast tail tends to get, it gets puffed up or the size increases once you're lactating the baby. So after delivery, for some time this lump may increase, and it may also remain for a long time. It may remain even after till the second delivery or till the next time. So the thing is, we don't have to worry. It's just that you can go in for a physical examination and get an ultrasound done. If the mass is only confined to the, tail of the breast, then it's nothing to worry except for the cosmetic part. So if you feel that, cosmetically it is not, it's not appealing, or it's irritating you, then you'll have to go in for that lump removal. If it is small enough, it's not affecting you, then you can continue. It is not cancerous, or it is not at all dangerous for the mother, for the lady.
Absolutely, ma'am. Now, coming to
Yeah.
my other query about the C-section, we
Mhm.
had a viewer who writes in to say that she went in for a C-section for her first baby, and she had a lot of pain in the stitches and all of that. So, in the second delivery, she went in for a epidural. But right at as when operation was about to take place or the epidural was about to be given, they asked her, "Are you feeling some sensation or pain?" And she said yes. So immediately, because of that fear, she was given GA, and as a result, the baby was in. She was also in coma, and the baby was not able to get up for 10 days or so. They had almost given up, and then the baby who was in a different section of the room, she woke up and is a normal child now. She wants to know if any abnormalities may occur in later stage, or the baby will be normal because of the effect of the GA going twice, I
Yeah,
guess.
see, normally cesareans are generally done either under epidural anesthesia or spinal. It's only if there is some contraindication to the procedure that a baby is delivered, a C-section is done under GA. Because generally, what happens is once you give GA to the mother, the effect of medicine may also go to the baby. And at times, the because of the anesthetic agents, the babies that are born are not active. They tend to be limp, so we generally try to avoid GAs for C-sections. It's only mothers with very high blood pressures, or if there is some problem in the spine that if she cannot be given a epidural or a spinal, that we give GA. And yes, a baby can be limp when it is born, but the effect is not long term. It is momentary. If the baby was in the nursery for 10 days or what, it could have been some other reason. It cannot be because of GA, because I mean, after GA, both mother and babies, they fare fine. They don't have such issues, which can be chronic or long term. So
Right,
we
ma'am. We
we
have a
have been
question.
doing it in selected patients, but then yeah, both mother and baby have been absolutely fine.
Another question, too, in fact, coming in from Mr. Sanjeev Puri. He writes in to ask about contraception as CUT duration precautions. This is an important question. And the second one, I don't know how to, say this aloud, because this is not a gender program, but how do you say, change the mindset of women who have two girls and who are still wanting another child? As a doctor, you must have faced these situations very often.
Yeah, yeah, yeah. So first is contraception, copper T. He wants to know about copper T.
Yes.
Okay. So basically, Copperty is an IUCD, which is an intrauterine device, which is kept inside the uterus to avoid any kind of implantation, and it inhibits pregnancy. So generally, Copperty is advised to couples who've already had one child. If you are newly married, we never advise Copperty, because Copperty can cause infections, and these infections can lead to tubal blockages. So it's only for spacing between two kids that we generally tend to advise a copper T insertion. It's a very minor procedure which can be done in the OPD, and it is done on the fifth day of the period, or I would say on the last day of the period. So we call the lady on the last day of the period, and it is just the copper T is just inserted inside the OPD. Now, there are two kinds of properties which are available in the market: a property which lasts for 3 years, and the other one which lasts for 5 years. And also, now these days, we have another one which lasts for 10 years. So, that generally a person uses after the family is complete. So, the 3 years has to be removed after 3 years, then 5 years, and whatever property, whatever you're using, it has to be removed in the stipulated time. So generally, properties are very well tolerated, but 10 to 15% of the females may have some, they may have some issues regarding prolonged periods. They may have some pain during menses, they may have heavy menses, or they may have some premenstrual spotting and some increased chances of infection. So otherwise, 85 to 90% females are very, very comfortable with properties, and I would say that this is one of the ideal methods of spacing in between babies. It is hassle free. Once you put it, you just have to forget about it, because if you're taking oral contraceptives, you just have to keep remembering the dates, and you have to swallow a pill every day, which may not be possible for many of the ladies. But yes, with copper T, there's a lot of convenience. Once you just get it inserted, and you're totally free, and you can be sure that and the failure rate is also very less. It's just 1 to 2%.
Absolutely. Now, another important question is about menstrual cramping and menstrual cycles. How do you define good cycles, doctor? And what is the way to cure the problems of some women who reach office, or sometimes skip office or reach office late because of the menstrual pain, which happens before menopause also? What is there to worry about? And what kind of treatment is available for this kind of cramping?
Actually, there are, we have to find out the reason for cramping. First, I'll answer you what is a normal menstrual cycle. So, cycles which have a duration, the duration between two cycles, if it is between 21 to 35 days, that is supposed to be an absolutely normal cycle. 7 days plus minus is also absolutely normal. Anything which is less than 21 days and more than 35 days is supposed to be an abnormal or an irregular cycle. Now, talking about cramps and dysmenorrhea or pain during menses, normally these cramps should not happen, but if they are happening, we need to find out the cause. And for that, we need a pelvic ultrasound. A pelvic ultrasound is very important. And once a pelvic ultrasound is done, we generally find a few reasons, and the commonest being fibroids. There are certain fibroids which may be placed inside the uterus, and these fibroids, they tend to cause severe dysmenorrhea. Another important reason is ovarian cysts. These cysts are very much common in the premenopausal, or they may also happen in the reproductive age group. So these ovarian cysts also can cause dysmenorrhea. And another very important condition is endometriosis. Endometriosis is a condition in which you tend to have those chocolate cysts and blood, blood going to the ovaries and all. So they also, even in that condition, the dysmenorrhea is very, very, I mean, it's severe. So a lady has to miss her office, she'll not be able to go to work. So, and there's at times certain infections. If the mouth of the cervix of the uterus, which is called the cervix, if it is tight, that can also cause dysmenorrhea. So that happens in cervical stenosis. So these are various conditions which can be diagnosed by a simple ultrasound. And if they are there, any of these is there, so we have to treat the condition. I mean, you'll have to go to a doctor and you would be advised medicines or surgery or whatever, depending upon the cause, whether it's a fibroid, it's an ovarian cyst, or endometriosis. So once a single ultrasound can just take care of the condition. And once you go in for the treatment, the dysmenorrhea may, it may decrease, or it may also disappear at times. Generally, females may go in for an ultrasound and there may be no problem, and still they have dysmenorrhea. So in such females, we give certain medicines which are OCPs, and these medicines, they avoid ovulation. They don't let ovulation to happen, and the period also which happens is generally painless, and it is less in amount. So we have to treat the cause.
Right, ma'am. Interestingly, you mentioned chocolates. I would like you to explain what are the symptoms and what is the way of treatment. Are all fibroids dangerous as well? This is another question to
Okay.
add to the cyst. How do you know you have a cyst? Is there some kind of pain associated with it, which is different from menstrual cramping? What is the way to find out?
Okay.
How do
So
you go
first
for an
I'll talk. Okay. First I'll talk about the fibroid. Fibroids are generally benign tumors or benign growths which happen inside the uterus. It's only 1% of the fibroids which may be malignant. So generally 99% fibroids are benign. Malignant fibers are those which are very fast growing, because normally it has been seen that fibroids grow at the rate of 1 centimeter per year. But if your fibroid is today 2 centimeters and within a year it becomes 5 to 6 centimeters, then there is a reason to worry. So, so we have to look at the rate of the growth and what is the amount of pain that is causing. So, if there is a lot of pain, if the fibroid is growing very fast or the size is huge, then there are chances that the fibroid may be malignant. Otherwise, fibroids are very, very silent and benign tumors. Now, regarding the chocolate cyst. Chocolate cyst is generally a complication of endometriosis. Now, what happens is, what actually is endometriosis? Now, we should first, I would just like to, talk upon the normal cycle. In a normal cycle, after ovulation, if the if the lady doesn't conceive, she just sheds her lining and it comes out in form of menstrual bleeding. Now this entire flow should come outside. But in some ladies, due to some unknown reasons, it has been seen, especially if her flow is very heavy. The blood not only traverses down, but it also traverses upwards towards the tubes and the ovaries, and also in the muscles of the uterus. So in such females, what happens is, the blood flow is very heavy. males, the blood gets collected and form a cyst. And now, since this is altered blood, with time, this blood, which is red in color, it becomes altered and it becomes brownish. And once you just rupture those cysts and see the fluid which is coming out, it is just like a chocolate syrup. So that is why we call these cysts as chocolate cysts. Now, how to diagnose these cysts. Generally, the commonest complaint is dysmenorrhea or pain during menses. Number one. Number two is irregular cycles. And number three is infertility. A lady has been trying to conceive for long, but she's not been able to conceive. And then painful intercourse. She's been trying to have intercourse, but it is painful. So these are a few of the complaints with which a lady lands up in the OPD. And if we go in for an ultrasound, we generally tend to see that there are some blood collections in the ovaries which turn out to be chocolate cysts on laparoscopy. So now, once you have been diagnosed with the cyst, we have to see what is the size. If the cyst is less than 4 to 5 centimeters, we generally go in for a medical treatment. We treat the lady for about a year or 2 years. We put her on conservative therapy, and the cyst size tend to decrease with time. But if it is a big cyst, if it is more than 5 centimeters, and apart from that, if a lady is keen for conceiving, suppose she is 35, 36, and she's not had started even her family once. So in that case, we tend to go in for a laparoscopy. We try to drain the cyst, we try to puncture, we try to remove the cyst, and we try to clear off. Because generally it is seen that once you have a chocolate cyst, it is generally bilateral. It may not happen in just one ovary. It generally happens in both the ovaries. And because of the effect of the blood, these ovaries get stuck behind the uterus, and the bowel may also get adhered. So such laparoscopies which we do for chocolate cysts may also be a little complicated. So they have to be done with lot of precision, and they have to be done very judiciously. But yes, once we clean them, a lady is fit for trying. But then, a word of caution, I mean, once you go in for a laparoscopy, it is very, very important that you should try to conceive within a year. If you do not conceive within a year, the benefits of laparoscopy are gone, and again, that cyst, they start forming in about 15 to 20% of the patients, and again those adhesions may happen. So I mean, we generally, we try to be aggressive after the laparoscopy for chocolate cysts.
Absolutely, ma'am. Two more questions. I'm afraid we're running out of time. I have so many questions to ask you. So I'll club these two with mine as well. Drugs to avoid in pregnancy, anemia in pregnancy, and what about bleeding if one has bleeding in early pregnancy? Is that common? Also, please explain PMS.
Okay. So bleeding first, I'll talk bleeding in pregnancy. So generally, see, once you get pregnant, you may have some bleeding at the time of stipulated time of your menses. Suppose whatever is your menstrual period date, you may have some kind of bleeding. So that is called implantation bleeding. So you are not supposed to worry for that. But once your pregnancy has established, and the heartbeat comes, and if you go in for that ultrasound, and if that bleeding happens, the ultrasound shows some bleeding, or you get some vaginal bleeding, then that bleeding is not normal. So you require some treatment. It could be because of hypothyroidism or infection or any other reason. So that bleeding has to be treated. Then at times, the placenta of certain ladies, they are low lying. The placenta is reaching up to the opening of the uterus. So even in such cases, when she exerts, or even if without exertion, there is some painless bleeding through the vagina, because of which which may be dangerous for the baby. Because at times, the if she bleeds very heavily, if she loses a lot of blood, she can also lose her baby. And at times, if your blood pressure is high, even in such cases, a female may have bleeding inside, because certain blood vessels, they just rupture because of high blood pressure, and because of which there may be some bleeding, and that is also not normal. So that also calls for a treatment. So these are certain conditions in which a female should approach the doctor if she has vaginal bleeding during pregnancy. So what was the other
Absolutely.
question? I just forgot.
The drugs in pregnancy.
See,
Yeah.
normally most of the drugs, I mean, the common drugs that we take, they are safe in pregnancy. But there are some drugs which are not safe in pregnancy. there are certain drugs, which should be taken with a lot of caution, especially in the first trimester. Especially, if you are on anti-epileptics, or you are on some vitamin A supplements, or you're taking some skin diseases treatment, some rheumatoid arthritis treatment, steroids. So there are certain group of drugs which have to be avoided. But generally, and I would say, for any kind of pain, crocin is the safest medicine in pregnancy. Any paracetamol is absolutely safe. The normal drugs that we give, the supplements that we give, they are all safe. But any kind of anti-cancer drugs, steroids, certain anti-epileptics, they should be avoided in the first trimester of pregnancy, and even
Anything you'd
later.
like to advise for UTI infection, ma'am, as we've already run out of time, and I'm afraid we'll have to do another session with you soon.
So you want to talk about UTI in pregnancy?
UTI, yes, recurring UTI.
Okay, so there are certain females, who tend to have recurrent UTIs. The commonest reason is, like, I mean, it's because of the workplaces. We all are working, and, we share the same public toilets. So that could be one of the reasons. Secondly, we are sitting for long hours in our chambers, and we don't frequently evacuate our bladder. So if there's a lot of urine stagnating in the bladder, it tends to get infected. So it is very important that, frequent passage of urine is important. Apart from that, if you're diabetic, you have that low resistance, and you are prone to recurrent UTI. And then, apart from diabetes, then if you have some kind of renal or kidney stones. So if you have a lot of kidney stones, your urine keeps infecting again and again, and you tend to have recurrent UTI. There are certain conditions in which, a female is not able to evacuate her bladder fully. In spite of passing urine, there is some urine which is still retained inside. So even in such conditions, the urine, it gets infected, and she can have recurrent UTI. If she has recurrent vaginal discharge, if she has vaginal infection, even in such cases, she can again land up in recurrent UTI. So we have to see the cause. And apart from that, the most important is your immunity. I mean, everyone has to improvise the immunity, so that you can just avoid these infections. Because especially if you're anemic, and you're not been eating properly, and you're stressed out, so everything, it decreases your immunity, and chances of recurrent infections increase, though there may not be any other pathological reason. So, and
Absolutely.
drinking less of water, another thing which
Yes.
is important.
Keep
Most of the
hydrated.
times, we have to drink water in a day. So they say at least 10 to 12 glasses of water in a day is very, very important to avoid
Absolutely.
UTI. Yeah,
And
yeah.
on that pragmatic note, I'd like to thank you, Dr. Anjana, for joining us today. Many
My
thanks
pleasure.
once again for sparing
My
your valuable time and coming on India Science. And with that, viewers, this is a wrap of this edition of Let's Talk Health. We'll be back with you next Monday for another yet interesting episode on Let's Talk Health. Until then, namaskar. Keep social distancing. Don't keep that mask away, and don't lower your guard. Thank you for watching India Science. Many
Okay.
thanks for watching once again. Namaskar.